Era, and we're going to talk about innovations targeting diagnosis and care in low-income setting. I would like to say that if you were expecting Keith Klugman from the Gates Foundation, he is not. I'm not Keith. I will be representing him. Unfortunately, he was unable to attend. And just because of the time here with a little bit of a late start, I'll just give you a very, very brief introduction, and to say that if you are here, you are interested in childhood pneumonia, and you know how important childhood pneumonia is in the causes of mortality and morbidity. We all, especially in the Gates Foundation, as well as you all, really work in trying to diminish the burden of childhood pneumonia, especially in low-resource settings where the burden is so great. We have had incredible advances, but despite these advances, we still have some pretty basic questions. First of all, you'll hear about the question of cookstoves and indoor air pollution. You'll also hear about life-saving treatment with oxygen and how to get oxygen to where it is most needed. And then another fundamental aspect of childhood pneumonia, which is how do we best diagnose it? And we'll talk about radiographs as well as lung ultrasounds. So despite all the advances, there's still a long road ahead of us, and I hope today will give us some new insights into these innovations. With me as a co-chair here is Eric McCullum, and he's a pediatric pulmonologist at Hopkins, and he has a lot of experience working in low-resource settings. So with that, thank you for being here, and thank you for all our speakers. I'm going to introduce Kevin Mortimer from Liverpool School of Tropical Medicine, who led the CAPS trial in Malawi, and will talk to us about CAPS. Thank you.
Thank you very much. And any chance of my slides, please? Okay. So that's not the start. That's the start. So I'm Kevin Mortimer from the Liverpool School of Tropical Medicine. Please forgive me for leaving after my talk because I have to give a talk somewhere else. It's not that I'm not interested in what follows, which is potentially much more interesting than what I am about to say. I was charged with talking about household air pollution and pneumonia in children and whether cleaner burning biomass-fueled cookstoves might be part of the solution, and drawing a lot on the experience of work that we've done in Malawi. So this is the little summary of what's to follow. I'd like to just share with you briefly the problem of household air pollution and the search for solutions. Mostly then I'll talk about the cooking and pneumonia study, touch on a couple of other trials of cookstoves and pneumonia, and then touch upon a potentially thorny issue of our major global investments in clean cookstove programs, really justified on the basis of health benefits. So just for context, what is household air pollution? Well, household air pollution is smoke from the burning of dirty burning fuels, so animal dung, crop residue, wood, charcoal, coal, burned in a dirty way, so burned in open fires, primitive stoves. And it's also smoke from dirty burning kerosene lamps, kerosene, of course, being a fuel distillate pretty similar to diesel, and we know how bad that is. And altogether, it's a major poverty-related environmental risk factor for premature death. Overall, if you believe the figures, it's responsible for something around 4 million deaths a year, and about 500,000 of those are pneumonias in young children. In this context, in 2010, the Global Alliance for Clean Cookstoves was established. They've got a program whereby they wish to see 100 million households around the world adopt cleaner cookstoves and cleaner fuels. And on their website, they have this piece about health. And if you can't read it, it says at the bottom, the adoption of clean cookstoves and fuels can save lives and reduce illness. I'd like you to remember that as we go through. Just to orientate you to Malawi then, for anyone who's not familiar with Malawi, Malawi is a landlocked country in sub-Saharan Africa, bordered by Zambia, Mozambique, and Tanzania. The study we called CAPS was done in 2 places in Malawi, right up here by the lakeshore in Karonga, and down here in a desperately poor and desperately hot area in the Shiri River Valley in the south. Malawi is a poor country, one of the world's, I think it's competing to be at the bottom of the ranks in terms of GDP, with a poor life expectancy, high under 5 mortality, and amongst the under 5s, pneumonia and diarrhea alternate as being the most common cause of death in the under 5s, so not an insignificant issue. And this problem of household air pollution is illustrated here. Here you can see a scene that's repeated right across sub-Saharan Africa, and in fact, some 3 billion of these world's almost 7 billion people cook in some kind of variation on this theme. 2 ladies cooking the staple food, sema, a maize porridge, over a 3-stone fire. You can it's difficult to take good pictures of smoke, but you can get a sense of there being a lot of smoke there. It's bothering them. It's as well as being a bothersome activity, and one we believe is responsible for 4 million deaths around the world each year. It's a basic day-to-day essential activity. It's not a choice. People have to eat. They have to prepare food for themselves. They have to prepare food for their children. So we conducted this study called the Cooking and Pneumonia Study, which was to determine whether a cleaner burning biomass-fueled cookstove called a Phillips cookstove, compared to continuation of open fire cooking, might reduce pneumonias in young children under the age of 5, diagnosed by the IMCI criteria. We used the IMCI criteria deliberately because that's the entity that is identified in Malawi and is associated with morbidity and mortality. X-ray confirmed cases of pneumonia don't exist in rural Malawi because there are no functioning X-ray machines. This is the stove burning in an optimal way. So called the Phillips stove because it was invented by the Phillips company. It's a chamber, you put biomass fuel inside, and because of the way in which it's designed, it's got a battery in that powers a fan that blows air through the fire and makes the biomass burn much more efficiently. And here's the scene where you've got a lady with her child using the stove outside. These stoves are portable, unlike the 3-stone fire, so they can be moved inside, moved outside, depending on other activities that need to be done, depending on the wind, the rain, and so on. In terms of preparing for our child, we did a lot of this, a lot of talking, a lot of community engagement, with each of the 150 individual communities in Malawi that were randomized to the study. We did a lot of things that many people told us we couldn't possibly do, including using smartphone technology for almost all of our data capture in rural Malawi. This worked really quite well overall, which smartphones can do all sorts of things, you know. That we take for granted, but you can use them to take photographs of the source document. So we did 100% source document verification of all of our cases of IMCI pneumonia by taking digital images of the health passports. So here's one where there was a diagnosis of pneumonia. And because of the digital transfer of data, we could review these in theoretically real time in Liverpool. We could see where all the households were, so we could easily track them using the GPS mapping function. So that bit of technology worked really well. This bit of technology not quite so well. The cookstoves, despite being designed for this kind of indication, for this kind of population, really were very needy. And needed, in fact, 2 stove doctors. This one is called Bright. 2 stove doctors in each of the 2 sites in Malawi. And here he's holding the main culprit, which is the lead-acid battery that powers the fan that blows the air through the fire. We had all sorts of trouble with these cook stoves. And we ended up, at least by the end of the trial, with a rather large graveyard of stoves. And something that keeps me awake a little bit at night is that we have some 10,000 of these lead-acid batteries sitting there in the rural Malawian environment with no way of retrieving them, recycling them. So they're being thrown in rivers, thrown in holes, burned in fires, Anyway. We did some of this, measuring carboxyhemoglobin levels in the kids. We measured personal exposure to carbon monoxide levels. This is a carbon monoxide measuring device that this little girl's wearing in a pouch. They really love these. This is how the mothers wear the mobile phones. So they called these mafoni, and they really didn't like giving them back to us. And they did all their own little experiments, the children. So they discovered for us that these Lascar monitors that cost about $100, they don't float. They don't they don't survive fire terribly well. And so we went through many, many thousands of dollars worth of those. What I'm hoping to show you now is a little film, which if it works, and I can't click on it myself because I don't have a computer, so I'm hoping someone at the back might click on play. And this is 3 minutes that tells you the story of the study and what the results showed.
In Malawi, pneumonia is one of the leading causes of childhood death, with around 15 in 100 under 5-year-olds diagnosed with the disease each year, and an estimated 1,000 young children dying from it. In a country where 95% of households rely on biomass as their main fuel, exposure to smoke from cooking on open fires is likely to be a major cause of childhood pneumonia. In rural Malawi, the CAPS clinical trial, a research initiative led by the Liverpool School of Tropical Medicine, set out to establish whether the use of advanced combustion cookstoves, which reduce smoke emissions, can prevent pneumonia in under 5-year-olds. In 150 communities, households were recruited to take part and were randomly assigned to the intervention group, who were given 2 advanced combustion cookstoves with a solar panel to charge them, or to the control group, who kept cooking on traditional open fires. During 24 months of follow-up, all participating households, a total of 10,750 children, were visited every 3 months and monitored on several indicators of exposure to air pollution and for episodes of pneumonia, as diagnosed to WHO standards. Cookstove use and economic and social factors were also evaluated. Across both trial regions, Chikwawa in the southern lowlands and Karonga on the northerly shores of Lake Malawi, there were 16,000 child years of follow-up data for analysis. Despite evidence that women liked using the stoves and used them substantially, no evidence was found that the intervention of 2 advanced combustion cookstoves and a solar charger reduced the incidence of pneumonia in young children. However, the advanced combustion cookstoves reduced the risk of burns and were well liked because they reduced cooking times and fuel consumption. The CAP study was funded by the UK Department for International Development, the Medical Research Council and the Wellcome Trust. It was conducted to high scientific standards in challenging and remote rural environments in one of the world's poorest countries. The result was clear. On its own, this cookstove intervention was not enough to prevent pneumonia in under 5-year-olds. Possible explanations for this result include that there were too many extraneous sources of smoke to show an effect. Clean air remains out of reach for the majority of the world's poor. The problems of pneumonia in young children and of exposure to household air pollution, globally 4 million people die of household air pollution every year, remain in need of effective solutions.
So that paper's in the Lancet if anyone would like to read it. And my last few slides are just about, to complete the story perhaps, there have been other trials of cookstoves and pneumonia in children, and there are some more in the pipeline and more to come. Firstly, a study in Mexico, then the Respire trial that many of you will have heard of in Guatemala, and then one we're waiting for the results for called Grafts in Ghana. This is the Patsari stove tested out in Mexico, a chimney stove, the Plancha stove in Guatemala, similar design stove. In Ghana, they're looking at these Biolite stoves on the right there, and these and LPG stoves. But altogether, the trial in Mexico found no impact on the primary outcome of interest. The trial in Guatemala found no impact on the primary outcome of interest. In secondary analyses, in all of these studies, and I think this is a criticism of almost all cookstove trials, multiple analyses, multiple secondary analyses, much fixation on positive findings from secondary analyses, per protocol analyses. But if you look at the primary outcomes of all of these trials, they've all been negative. So this is my last slide. I think the answer is no. I think that at this point in time, we can't justify investing in cleaner cookstove programs when there are proven effective and cost-effective interventions out there. What is needed is more research to understand what could potentially make a difference in those settings. But whilst that evidence is being generated, we should be focusing our investments in those things that we know that do work.
Thank you very much. Because Kevin has to leave, I would like to entertain any questions from the audience. I have one question. We could talk about household air pollution for a very long time because it is quite an interesting and controversial subject. But in all of these, is there a factor that one could think is the factor? Is it that we're not getting the levels of particular matter in children measured and low enough? Is it the use? There's been a lot of issues of compliance. Do people use the stoves often enough? Do they use a mixture of their traditional stove with the new ones? Is there some idea of LPG, a cleaner solution, being the better solution? How would you say is the best way to move forward in this field?
So I think that we need to challenge the conventional wisdoms and we need to just be a little bit more sophisticated in our thinking. I think the idea that you can just replace open fires with cookstoves and pneumonia will go away and COPD will go away and women won't be raped because they're not going to look for firewood. All sorts of outrageous claims that have really, I think, harmed the area really need to be challenged. And actually, we need to go back to, well, what is it that we think is causing the problem? Well, it is, as you've said, it's the particulate matter exposure. And so by taking out a single aspect of it, let's say the open fire, but you leave the kerosene lamp burning away, and you leave the fields burning away, and you leave the dirty diesel trucks driving past and the factory belching out smoke, well, you're not dealing with the whole problem holistically. And so I think that in in my view, it's time to move away from single isolated interventions and look at addressing the issue of air quality.
Thank you very much. Thank you. Thank you for a great talk.
Okay, so I have the pleasure of introducing our next speaker, Dr. Nick Boyd, who is a pediatric anesthesiologist from the United Kingdom. He works with Lifebox Foundation, who today is launching their new pediatric pulse oximeter. And they have an exhibition area in the tech innovation section of the conference. Please visit if you're interested. And Nick has more than 5 years of global health work in many different countries, and we're excited to hear from you.
Thank you very much, Eric. Could I also have my slides? That would be great. And I think this talk is going to follow very well from Kevin's talk, because I'm going to focus on one of those interventions that I think does work. That's not a joke. But this talk would be so much better with my slides. Aha. Does that make it easier? There we go. So I'm going to talk to you about a really exciting project, and it's a real privilege to be able to talk to you about it here at this at the Union Conference. It's the first time that we've presented this work, and it's the result of about 18 months of hard slog from a number of different people. And it's about pediatric pulse oximetry and its role in low-income countries. As we've heard, my name's Nick Boyd, and I'm a consultant pediatric anesthesiologist from the UK, and I work with the Lifebox Foundation. So a bit of background. We've already heard from Kevin, so just to sort of drill it home, pneumonia is now the leading cause of death in children under 5 years old, causing an estimated 1 million deaths every year worldwide. The vast majority of these occur in low-income countries, low-resource settings, such as Malawi, as we've just heard. So severe pneumonia is associated with hypoxemia, or low blood oxygen level, and that has been shown to be a strong predictor of mortality. Hypoxemia can be measured non-invasively using a pulse oximeter and is far more sensitive than using clinical signs alone. Pulse oximetry now is widely regarded as improving pneumonia care in these patients, and when combined with oxygen therapy, which we'll hear a bit about in a minute, later on in this session, can reduce mortality by 30 to 40%. As we also probably are aware, pulse oximetry has been widely used in high-resource settings for about 3 decades. It's relatively expensive. The actual oxygen monitors, the oximeters themselves, are relatively expensive, not hugely, but fairly. They are, just focusing on pediatric use, we routinely use these probes like the one shown in this picture here, which are single-use disposable adhesive probes, which cost about $10 to $15 each and make it completely unsustainable and unaffordable for low-resource settings. So in summary, there is currently a lack of a reusable, affordable pulse oximetry probe for use in this age group designed specifically for low-resource setting use. I'm going to tell you a little bit about Lifebox, just in a couple of slides, because I think it's important to set the scene. Lifebox is an NGO, a non-for-profit organization that focuses mainly on improving safety for anesthesia and surgery in low-resource settings. It's been around for about 5 years, and since then it's distributed about 16,000 affordable, low-cost, robust, battery-operated pulse oximeters to a huge range of countries, but mainly low-income countries. It's headed up, the chairman is Atul Gawande, who's a well-known US surgeon and author, and its CEO is Chris Torgerson, who is here with us today. So if you're interested in this part of medicine and pneumonia care, it really is a good chance to come and grab us at our stand or after this talk. We'd be really keen to talk to you. And this is the current Lifebox pulse oximetry probe that is distributed with the Lifebox pulse oximeter. It's an adult probe. It's called the universal probe, but from work done in low-income countries and on pediatric patients, it was very clear that this wasn't particularly suitable for children, and particularly as a spot check device. So the aim of this project was to develop a reusable pulse oximeter probe for use by frontline healthcare workers on children under 5 years old. And it was funded by the Bill and Melinda Gates Foundation. So this was a real collaborative effort, and I just want to focus a little bit on how we actually did this project. So it was a real collaboration between industry, expert clinicians, and healthcare workers at the front line in a number of low resource settings, okay? And it was really important, I think, to sort of demonstrate this. I just want to show you this photograph. So this photo is taken from Malawi, and apart from Eric on the left, who's very important, I just want to focus a little bit on Linda here, who's on the lady on the right. So Linda Cheng, who is the CEO of A-Care that make Lifebox oximeters, and she was there on the ground seeing how they were being used in practice in this setting to try and influence how the pulse oximeter might be designed in the future. And this chap here is Mike Bernstein, who is a world-leading expert on pulse oximeters. If anyone's a bit of a geek and wants to know a bit about pulse oximeters, he's the man to talk to. And here he is. He was there on a number of visits to Malawi watching these pulse oximeters being used. And that heavily influenced the way that we went on to design this final probe that we've created. And I think it's quite a useful example of how this type of work should be done. I think we need to work much more closely with industry, and industry needs to work much more closely with clinicians, particularly when we're designing bits of kit for areas that we perhaps don't understand as well as we think we do. So at the end of this sort of 12-month process, we ended up coming to the stage of actually testing our prototype. And I'm going to talk to you a bit about how we did that and some of the preliminary results that are as yet unpublished. This is one of our healthcare workers in Malawi testing the probe on a neonate. And what we essentially did was we designed a testing process that was an iterative testing process. It meant that we could alter that prototype design as we went if we felt that was the needed. It involved experts and end users in low and high resource settings. And our primary outcome was the time to obtain a quality oxygen saturation reading. And the reason we did that was we felt this was probably the best objective measure of overall usability. At the end of the day, these pulse oximeters are about getting an oxygen saturation reading, and time to achieve that is probably the ultimate in terms of how usable it is. We had a few other secondary outcomes, but that was our main primary outcome. We had a number of rounds to our testing. So round one was in Malawi, where we tested healthcare workers and experts. We also tested against another market-leading box just to see how our pulse oximeter compared to that, and there wasn't any difference between the two. And we got some feedback after that. We then went on to test in Bangladesh, and we did the same process that we did in Malawi. After those two rounds, round 1 and 2, we made some minor probe modifications because there was a clear feedback that we could improve this probe in a couple of areas. So we made a couple of minor modifications before going on to test the slightly updated probe in the UK with highly trained nurses and, again, experts. And then again, we got some feedback and made some minor probe modifications before going back to Malawi and testing it just with expert users and coming up with our final design iteration. Overall, these were our sort of headline results. So we managed to achieve an oxygen saturation reading, a sort of quality oxygen saturation reading in less than 1 minute in 67% of occasions, in 81% in less than 2 minutes, and 90% in less than 5 minutes. Looking at the difference between experts and healthcare workers, in readings under 1 minute, there was no difference found. However, there was a slight indication towards the less than 2 and less than 5 minutes that experts perform better than healthcare workers. And these are the more challenging readings. That's why they were taking longer. These are children who are going to be more challenging to take readings on, and we could see some divergence between the healthcare workers and the experts. Importantly, we didn't see that difference in the high resource settings. So there's no difference between experts and healthcare workers in Great Ormond Street, which is where we tested in the UK. But there was a difference between healthcare workers in Bangladesh and Malawi and experts in Bangladesh and Malawi. Looking at the final sort of stage of our testing, round 4, where we just tested experts with the final probe iteration, we found that we were able to get a reading in 61% of occasions in less than 1 minute, 79% in less than 2 minutes, and 100% in less than 5 minutes. And ultimately, we wanted to get a reading in less than 5 minutes. We felt that any more than that, and it was really not a particularly usable device. We also went on to look at whether there were factors associated with particularly challenging readings in less than 1 minute. So we used an adjusted odds ratio technique, and essentially here, a higher adjusted odds ratio means that it's easier to get a reading. Okay, there were more readings in less than 1 minute. So you can see from here that there was a statistically significant difference as a child got older, that it was easier to get a reading. So essentially there were more readings possible in older children, and it was more challenging to get a reading in infants and neonates, i.e. less than 1 year old. We also looked at the condition of the child to see whether that had an influence on whether it was easy to get a reading, and found that, again, it was more challenging to get a reading when there was any sign of movement, whether the child was agitated, crying, and that was far more challenging to get a reading on those children. And that just highlights, I think, the areas that we need to focus on if we're going to make this a really, really good bit of kit for low resource settings. So movement and particularly very, very young children. I'm going to talk to you a little bit about the probe design in the final, how long have I got? 5 minutes, fantastic. So this is the first time I've ever been able to show this probe at all, any sort of in any detail. We just released the patent design a couple of days ago. So this is the overall probe design. At first glance, it looks fairly similar to many pulse oximetry probes that you'll see out there in clinical use. Slight differences that you might see, it's a little bit longer than a normal pulse oximetry probe, and that's because it's been designed for a foot of an infant or a neonate, but it can be used on a finger of an older child. The cable has always gone towards the patient in pulse oximetry, reusable pulse oximetry probes, because they've been designed mainly for anesthesia. This probe goes towards the user, which makes much more sense, and that was one of the feedback things we got from healthcare workers in Malawi. The hinge is really important. So I just want to tell you a little bit about, this is really geeky, I'm sorry, but the hinge is really interesting. It allows the probe to be opened really widely with one hand, which allows the user to use their other hand to support a child's foot or a child's hand and open that probe fully to get it into the right position. It also opens up, once it's on that child, on a chubby foot, it will open up to allow those two arms of the probe to be parallel to each other and get a better reading. And you can see here it's being used on a neonatal foot across the foot, and that's one of the ways that we have found that healthcare workers are using this probe. So it's a really useful, versatile way of using a probe. This is just to show how you can open it with really widely with one hand. The pads themselves are very soft. They've got no hard edges, which the old universal probe had, making it much more comfortable. And it sort of molds to the foot, as you can see on the photo on the right. It molds around the foot and is really well tolerated. I mean, there were lots of occasions that I was using it as one of the experts that I was on an asleep child or a really settled child, and it wouldn't disturb them at all, which is really different to what you'd get with the old universal probe. The position of the LED is towards the hinge end, so the long arms here sort of support the probe in position, and the LED itself sits over the toe, which is what you'd expect and what you'd want. And there's also some slightly firm silicon tubing underneath the detector site to reduce some of that movement artifact that you get. We found that, as I said in some of the results, we realized that there were a reasonable number of occasions where healthcare workers were getting a reading that they thought was the correct reading, but in fact was not a particularly good oxygen saturation reading. And I think that highlights to us the importance of education and training when implementing this type of technology. Even what we think may be relatively simple to use, it's actually it can be quite challenging. And although most of the time healthcare workers with very, very little training would use it appropriately, education is a really important aspect. So we've created a couple of educational aids to go alongside our Lifebox pulse oximeter. I've turned the sound off just so I can talk over it, but the video on the left is a sort of 5-minute video that talks you through how to take a spot check reading using this device. And the poster on the right is a wall aid that can be used in clinics, in pediatric outpatient clinics, or in a triage room, and just describes how to place a probe and how to get that quality reading, making sure that you've got a reliable pleth trace and oxygen saturation reading that you think is appropriate for that child. So, in summary, I think the first thing to highlight here is that this has been a really fascinating collaborative effort between industry and clinicians, that we've engaged with end users from the outset and designed a probe that reflects that. We think we've designed an innovative pediatric oximetry probe, and our results, we think, are encouraging for a reusable and, importantly, an affordable pulse oximetry probe for this kind of setting. It's very clear that movement, and particularly the very young children, less than 1 year old and less than 1 month old, are particularly challenging groups, and that's probably where further focus should be in terms of future development. But it's really important that task-specific training is implemented alongside this type of technology. But overall, we think that with appropriate training, that this is a suitable probe for widespread use in low resource settings that could have significant implications for the management of children with pneumonia and other illnesses in low-income countries. Thank you very much.
Thank you, Nick. I think we're going to hold questions until the end so we can make sure we have enough time for all the talks.
Great. Well, a great follow-on to that is now we know how to measure it, and now we're going to talk about the importance of treatment with oxygen. And Hamish Graham is here. He's a pediatrician at the University of Melbourne who also has experience in low-resource settings. He also works at the University College Hospital in Nigeria. Thank you, Hamish.
Thank you, Gail. I'm really excited to be here today to talk to you about something which I'm very passionate about, and that's providing oxygen to children. And I've got 3 goals today. Firstly, I want to sell you a vision of oxygen for all children. That means oxygen getting to every sick child that needs it whenever they need it. Secondly, I want to show you where we are today in achieving that vision. And thirdly, I want to highlight 5 things that need to change if we're actually going to reach that vision. Now, I'm drawing on 2 main sources for this talk. The first is a systematic review of oxygen projects that we conducted a couple of years ago, which involved 45 published and unpublished studies from 20 oxygen projects across 15 countries. And I want to acknowledge all the people that I hassled about this and thank them very much for their input. The second source is an ongoing project called the Oxygen Implementation Project in Nigeria, and we're very lucky to have Professor Faladi here in the audience today, who's the PI on that. And so I want to give a big shout out to Professor Faladi and all his hard-working team in Nigeria. Now, you all know about oxygen. You're breathing oxygen now. You know that it's essential for life. Even a few minutes without oxygen is catastrophic for cells. What I'm talking about today is oxygen therapy. So I'm talking about simple low-flow oxygen therapy, and particularly in the child setting. Now, this video, I'm not sure if this video will work for us, but let's just give it a go. This is a young child who has pneumonia. She's very sick, drowsy, almost unconscious. If the video works, you'll see her breathing very, very hard. And can anyone read what's on that lovely Lifebox oximeter there in the purple? What's that number there? This is the SpO2, 49%. So 49% is extremely low. And this indicates the severity of her pneumonia, severity of her disease. It looks like we're not getting the video, so we'll move on. So this is just a couple of minutes later. All that's changed is that this child is now on oxygen through nasal prongs. She's looking a bit brighter. She's still breathing fast. She's still obviously very sick. But what's that number there now? 98%. And this is with half a litre of oxygen, 0.5 litres of oxygen. Oxygen, simple low-flow oxygen, can be life-saving, and studies have shown that it can reduce death rates in severe pneumonia by around a third. Now, that doesn't mean that oxygen alone saves lives. Obviously, this child also needs treatment for the underlying cause, the antibiotics, supportive care. And it doesn't mean that every child who has breathing problems will just need respiratory support at this level. Some children, some adults will need greater respiratory support. But simple, low-flow oxygen therapy really is life-saving. Now, I want to quickly show you a bit about this amazing innovation of oxygen. It was discovered back in the 1770s. And for the next 100 years, so just to put that in perspective, that's about 100 years before X-ray was discovered. It's about 150 years before penicillin and 200 years before we had the first pneumococcal vaccine. For the next 100 years, nothing really much happened with oxygen, except that it was sold on the street as a sort of cure-all by charlatans. So it was a kind of a luxury item for those who could afford it. But that all changed around the 20th century. When Scott Haldane, pictured here, wrote a treatise on oxygen, which pretty much taught us almost all we know about oxygen now. And that time also coincided with World War I, which gave a chance to actually test a lot of this in the field. So a lot happened in the next couple of decades. So the survival benefit of giving oxygen was proven, as well as many other things that you can see here. And I'll show you this for two reasons. One, to show you that oxygen has been around as a therapy for a long time, and I want you to remember that as we go through the presentation. And secondly, to say that a lot of the misconceptions and challenges facing oxygen even 100 years ago are still misconceptions and challenges facing the delivery of oxygen for children in many places of the globe. It's still, in many places, a luxury item that's only available to those who can afford it, and it's still given in very inefficient and ineffective ways, including intermittent oxygen therapy rather than continuously. Okay, so where are we now? So I want you to imagine this box shows you all the children that need oxygen right at this moment. Now, the answer to where are we now with oxygen really depends on the question that we're asking. If we're just saying, does your hospital have oxygen equipment? Does it have oxygen cylinders? Does it have oxygen concentrators? Then we might get a pretty high answer, about 90%. In the hospitals that we're working with in Nigeria, 12 hospitals, only one of them had absolutely no access to oxygen when we started. The other 11, they at least had something. But when we ask, does your equipment work, that starts to drop. We tested about 50 concentrators in the hospitals, our 12 hospitals. We found 3 of them that could produce medical grade oxygen, and only one of them had appropriate electrical specifications to actually be used in Nigerian hospitals. If we ask, do your staff have the skills to use it appropriately, the percentage drops even more. And if we ask, do patients get oxygen when they need it, it's in the vicinity of around 10%. So in the last 100 years, we haven't really come that far if only 10% of children in low resource settings that are admitted to hospital that need oxygen will get it. If we ask, are they getting it at the right time, in the right way, and for the full duration, then it's probably even lower. So, what are we going to do? Well, first we need to ask the right question, and if that's not obvious, this is the right question. Are the children, are the patients that need oxygen, are they getting it? And that's a big change from how oxygen is talked about generally. Generally, we're still talking about this, have you got equipment in your hospital? And that's clearly not enough. Secondly, we need to focus on the patient. And this is something which is probably very obvious to all of you in the room, but it's unfortunately not immediately obvious to many people in industry and many policymakers. We've heard a very good example just now from Lifebox about how to take industry, to take product development to the patient and develop it for the patient. That is unfortunately hasn't been happening with oxygen, with very few exceptions, and there's a very, very big need. Thirdly, we need to understand how oxygen works. This is a schematic which came out of the review of 20 different oxygen projects, and I'm not going to go through it in detail, but I just want to highlight a couple of things. Firstly, getting oxygen to children, to sick patients, requires good oxygen access, and that involves not just good quality equipment, but also the technicians and the systems that will keep that equipment working. It also means making oxygen affordable, and I mean affordable both to hospitals and to patients. In the hospitals we work with in Nigeria, hospitals told us how they were tens of thousands of dollars in debt to oxygen supply companies, that every month they were fighting with the oxygen supply companies to please just send a few more cylinders of oxygen. Oxygen is extremely expensive to supply to hospitals. On the patient side of things, oxygen costs for a child who has pneumonia and needs oxygen for a couple of days could send that family into debt. It could be more than the combined cost of all other treatments for that pneumonia. The other side of providing oxygen is how oxygen is used. Now, this obviously requires skilled, confident healthcare providers who are motivated, who understand how oxygen works and are convinced of the importance of using it. But it also involves creating an environment where they're able to use it well, where they've got, where it's easy for them to assess patients whether they need oxygen and provide oxygen whenever they need it. And our approach in Nigeria was to do this centred around a multidisciplinary quality improvement team at the hospital level. And we found this was a really effective way of bringing together all the different players, from administrators, technicians, doctors, nurses, who would make this actually work. Now, this is quickly what it looked like in our hospitals. Obviously, in different places it might look different. Up in the top left you can see part of the team. We've got nurses, technicians, doctors. We've got some of the equipment, so we're using oxygen concentrators. From one oxygen concentrator we go through a flow meter assembly so it can be shared to up to 5 patients. Pulse oximeter is not pictured there, but you can see an oxygen analyzer so the technician can always check whether that oxygen that's coming out is truly medical oxygen. You can see our installation crew putting it in, training the technicians down on the left about how to maintain and look after it, and the clinicians here on the right. Now, fourthly, we need to do pulse oximetry. And we've already heard about pulse oximetry, but I really can't emphasise this enough. And I want to show you just something really briefly that's been surprising from our study. So when we started back before November 2015, none of the hospitals were really using pulse oximetry, but you can see over time that improved. So that line is the average over the 12 hospitals, and I've got 2 example hospitals, the blue and the orange. When we look at oxygen use, we see a very similar pattern. So oxygen was being used before we started the project, but it increased linearly. The interesting thing is all hospitals had pulse oximetry introduced at the start. But the rest of the intervention, the big package of oxygen, actually came later. So the blue hospital got it quite early on. The orange hospital actually got it very late. So you can see that even without the improved oxygen supply, by having pulse oximeters and being able to identify the children that needed oxygen, these hospitals were already changing the way they allocated the oxygen resource and gave oxygen to children. Finally, we need to think bigger than just pneumonia. This is a little schematic that I drew up showing hypoxemia prevalence on the left and age on the right here. So the first thing you sort of notice is that hypoxemia is a lot more common in younger age groups and dwindles around, but is still significant in the older age groups. Secondly, each of these balls sort of represent you can think of it as potential life saves relative to different conditions. And you can see for pneumonia in the blue, it's a big ball, it's the biggest one there. But it's not the only one there. And I think if we only talk about oxygen with regard to pneumonia and we don't bring in our malaria colleagues, our neonatal colleagues, then we're missing a big opportunity to convince policymakers who, let's face it, don't care that much about pneumonia generally, and draw financing. And what we've certainly found in Nigeria is that hospitals are very happy that we've done this for kids, but they want us to do it for the adults, and they're willing to pay for the adults. Adults are generally more willing to pay. So we've had oxygen as a medical therapy for over 100 years. We've still got a long way to go to actually make oxygen available to every child that needs it. We need to ask the right question. That means focusing on the patient. Are the patients that need it actually getting it? We need to understand how it works, and a big part of that is pulse oximetry to accurately identify who actually needs oxygen. And we need to think bigger than pneumonia. Now, yesterday we heard some talk about the tipping point for childhood TB. I'm not sure we're approaching the tipping point for oxygen for children, but I'm hoping that in the next few years we're going to get close and see some big changes. Thank you.
Thank you very much. We'll hold questions till the end.
Okay, so our next speaker, I have the pleasure of introducing, is Dr. Nick Fancourt. Nick is currently practicing pediatrics in Darwin, Australia. He has a PhD from Johns Hopkins School of Public Health and is also currently associated with the Murdoch Children's Research Unit. And today, Nick is going to be talking about his experiences with the WHO Chest Radiography and Epidemiological Studies Group and X-rays overall as a diagnostic tool for children. Thanks, Nick.
Cool. Thank you, Eric, and thank you very much for the very special invitation to be here today, and welcome to you all. So I have been spending the better part of the past 5 or 6 years working in chest X-ray diagnosis for pneumonia within the context of epidemiological studies primarily. And what I'm presenting today is a bit of an update on an ongoing project that's aimed at providing some increased resources and support for investigators and site staff within ongoing epidemiological studies. Try as I might, I still have no conflicts of interest. So just as a bit of background, diagnosing pneumonia in general is a little bit complicated with any degree of accuracy. But measurement of pneumonia cases in epidemiological studies is also particularly challenging. Chest radiographs have been a very commonly used tool across studies for the past several decades, and they offer some intuitive benefits in that we think they are able to sort of visualize lung fields and give us a sense of what we think is going on, as inaccurate as that might be. They provide a permanent record that allows us to go back and provide reinterpretation and revalidation of studies. But they also remain imperfect. They are incredibly technically challenging, and their interpretation is also quite subjective. Particularly in the field of pneumonia, where we're still using human interpretation primarily. And in response to those concerns, the WHO led a very expansive effort to standardise the interpretation of paediatric chest X-rays in the lead up to the bacterial vaccine trials. So beginning about 1999-2000. And went through a process of identifying several definitions of primary endpoint pneumonia, which was one of the primary endpoints for those vaccine trials, definition for other infiltrates and a definition for normal X-rays, as well as a categorization around the quality of the film. The purpose of all that was really to optimize the interpretation for the detection of Haemophilus influenzae and the pneumococcus, because those were the targets of the vaccines. And the WHO also led a bit of a supporting network of activities and resources that would provide backup to site staff, centralised arbitration processes for resolving discordant films and the like. And some of what we are doing is really trying to reignite that process because it was quite useful. So there was quite a bit of success in the use of that standardised methodology in the vaccine trials. There was very similar levels of observer agreement, which we'll come to later, and very comparable vaccine efficacy and effectiveness findings, despite different geographic contexts. And the enthusiasm that came from that meant that chest radiograph diagnoses in epidemiological studies became a bit of a standard protocol, and there was widespread uptake. So into antibiotic trials, into air pollution reduction trials, particularly the Respire trial in Guatemala, It was used in the RTSS malaria vaccine trial and a number of etiology studies, a lot of surveillance and incident studies, and then as a method of case selection to get into certain studies. But there was at the time of all that increase post the major vaccine trials, there was this decline in centralised support for chest X-ray activities. And alongside that declining support came this role of emerging concerns of drifting standards and imprecise definitions as individual study groups were kind of left to find their way through the definitions by themselves. So this is where the WHO Chest Radiography and Epidemiological Studies project was born out of almost 2 years ago. It was formed to sort of renew the support activities for chest X-ray resources, supported by the Bill and Melinda Gates Foundation under a broader context of PCV technical coordination work that's been held between Johns Hopkins and the WHO. And aside from a core list of investigators, really at the heart of what we do has been a 14-member technical working group of expert physicians and radiologists, most of whom have had quite extensive experience in using the methodology across the past 15 years. So our objectives were to provide some clarifications to the definitions and to expand the reference library of images that were available for training readers and to evaluate some inter-observer variability in the use of those reference images. And then also to develop some new guidelines to support the quality and safety of radiographic techniques within studies and to give some guidelines for training and assessment of readers. We've also got a centralised process now for resolving discordant images with centralised arbitration and to think a little bit about what the scope of these definitions are beyond vaccine trials. So I think it's useful always to talk a little bit about exactly what we're talking about because it's a slightly more simplistic set of definitions than what a lot of the TB X-ray diagnosis enables us at the moment. So the normal chest X-ray film with clear lung fields and a normal heart border. And then this concept of primary endpoint pneumonia has two components, and the first component is endpoint consolidation, which is defined, and if you just read what's written there, a dense and or confluent opacity that occupies a portion or a whole of the lobe of an entire lung that may or may not contain air bronchograms. You can imagine that just reading that becomes quite difficult, and so there is a sense of needing some iterative training between looking at the film and looking at the section where there is this dense or confluent opacity and a portion or a whole of a lung and matching it up with what you're reading. And that's a part of the process that we're trying to reignite to, getting a very strong training process. As part of what we've been through and reflecting on a couple of high-level meetings that we're again trying to evaluate the definitions, we've adopted a couple of footnotes now to the definitions, which have been published in Pediatric Radiology a few months ago. And they're one to define the use of a portion of a lobe so we can get some sense of size. And we do that by looking at trying to take the size of consolidation relative to the distance between two posterior ribs. And the idea is that if the size is bigger than two posterior ribs, then you hit the mark and you can call it a consolidation. And the hope is that removes some of this imprecise definitions, use of the definitions that was floating around. The other footnote we've added is the explicit definition of the silhouette sign, so the loss of a normal anatomical border. So here where you should see the right heart border coming down and you miss seeing that, acknowledging that in the presence of an opacity also represents some endpoint consolidation. And again, I'm not running through this with the purpose of trying to teach you, but trying to just let you know a little bit what we've done and how we're trying to train our readers. The second component of the primary endpoint pneumonia definition is pleural effusion, and here again we're really trying to maximize specificity, and we're really trying to look at barn door large pleural effusions. So we don't tend to differentiate between small effusions and horizontal fissures or elsewhere. And the rule of thumb that the trainers often give is if you think maybe it's there or maybe it's not, then maybe it's not is the way to go. And the in-between of the normals and the primary endpoints is this definition of linear and patchy opacities. So things that are not entirely normal, but we don't think represents bacterial disease. And that's termed other infiltrate. It also includes patches of of opacity and consolidation that are not quite big enough to meet that definition of endpoint consolidation. And so here's just a table outlining some of the experience with interpreting chest x-rays within studies, and gives you a sense of what's normal for us in terms of observer agreement. So if we jump down to these two lines here, these are the two PCV trials that reported on their consolidation findings of primary endpoint pneumonia, and very similar measurements of observer variability with a kappa statistic of 0.58. The large case control pneumonia etiology research for child health study, which we published on just earlier this year, again showed with a 14-member panel of readers and a 4-member panel of arbitrators, kappa of 0.5 and 0.6. And in incident studies, we've seen similar measures of 0.58. And we do get high measures in other studies, but this is just reflecting that also that the kappas very dependent on the prevalence of the population in which you're measuring the disease in, and so very dependent on the protocols that are being used. So jump back into a little bit of what we've been doing. So we've developed a new set of reference images, and to do that we asked our 14 members of our technical reference group to look at 50 of the established reference images that were already in existence. And we calibrated that group against the old group that made the first set of reference images, and made sure that they were closely calibrated with the primary endpoint pneumonia. They detected that with a sensitivity range of individuals between 83 and 98%, and across all conclusions from 71 to 96%. And in a training scenario, that would be considered a pass. And then we've got them to read a new set of 400 images, which we've gained from a couple of international studies. And of those, 315 had a majority diagnosis, where at least 50% of all of those readers of the technical working group agreed on the diagnosis, and 209 with what we call a consensus diagnosis, or more than 66%. And just a breakdown of the distribution of findings between the 14 readers, and the red column is probably the important one to show that there's a variation there between about 20 and 45% of primary endpoint pneumonia between readers. And this is really just to highlight to you amongst the chest x-rays of what's sort of easy to see and what's not, and you can probably get a sense from what I showed you earlier. But if you look at the primary endpoint category here, you can see most of the primary endpoint detected actually had quite high levels of agreement. There's a 90 to 100% of readers agreeing on the primary endpoint pneumonia being there. Some in that 66 to 89%, and then a little bit down here in 51 to 65. You can see that for other infiltrate, that sort of skews the other way, and that's because it's a much harder definition to get agreement on, and there's nothing that surprises us too much about that. And amongst these images, these are the images where there was 50% agreement, so it's a bit of a select group. But just to reaffirm that there is a higher level of observer agreement for the primary endpoint pneumonia. And so the use of the definitions and trying to distinguish these things is of this utility. And here's our 14 readers, and just looking at their observed agreement here in blue, and their overall kappa statistic in blue, ranging from here about 0.53 up to 0.78, 76, I think it is. And down here in the green, just again, the proportions of primary endpoint pneumonia that each of them were detecting. And just a little bit of a note on training and standardization. So we've developed now a module for training and standardization of readers. So we've got these reference images with descriptive comments attached to them, with the definitions, and also with illustrations of those images. And a varying training intervention, which is a teaching program that can be tailored depending on the scenario and the study. The standardization assessment we've set up requires testing with 75 images, 50% with primary endpoint pneumonia, aiming for a post-intervention kappa of 0.75. And the one group that we've run this with at the moment have shown an agreement for primary endpoint pneumonia pre-test from 0.63 up to 0.82, and agreement across all conclusions from 0.51 up to 0.68. I've got one slide on quality and safety. I think this is potentially one of the most important things that we've done in this project. And we've developed a huge number of resources for site staff and investigators to be able to come to a single source to gain some knowledge on what to do when setting up radiology for a study. And we've split into 3 different sections. One's a pre-study survey, which looks at essentially a site need assessment running through personnel, facilities, equipment, processes and safety measures. And then some guidelines for studies, so looking at factors related to quality of chest radiographs and helping to assist in the development of operating protocols and standard operating procedures. And then a third section that's all about quality assurance. What measures do you go through at what time intervals to make sure that your equipment and people and facilities are being kept up to scratch? And also include some guidelines on using routine image analysis, then create some feedback to the sites about how to have some 360-degree review on their imaging processes. So a little bit of the resources that are available coming out towards the end of this year. So the website that we have will be up hopefully by the end of this month. We're just drafting the final content for that. There's a couple of written resources. There is one preliminary publication in pediatric radiology, which I haven't put up here, which is already out. There'll be a WHO numbered document update, which is the central reference with all of the background materials, and also an updated bulletin article which outlines the major activities around clarifications and the observer variability study. And then the main piece of all of this is to provide some ongoing support and resources for investigators so that we're around to assist with helping with protocols and training of readers and providing centralized arbitration, and to keep thinking and applying and understanding how this methodology is really being applied beyond the vaccine trials. So I guess the key take home is that there's a group around if anyone needs some support. That's me.
Thank you, Nick.
We have our last speaker, and it's a pleasure to introduce William Checkley. He is a pulmonologist and critical care specialist at Johns Hopkins School of Medicine, and he also has a lot of experience in low resource settings, and will talk to us today about lung ultrasound diagnosis of pneumonia. Thank you, Will.
Well, thank you very much for inviting me to present here today. So I will follow this up with a discussion on lung ultrasound. Just wanted to say no conflicts of interest, and our work on lung ultrasound is being kind of funded through different sources, including NIH and more recently by the Bill and Melinda Gates Foundation. So the objectives of this presentation are the following. I just want to focus on the use of lung ultrasound for pediatric pneumonia, and just on 3 different points. So is it do we need better point-of-care diagnostics, and could ultrasound be part of this? Is ultrasound a reasonable alternative to chest X-ray, or at least a complement where available? And does the use of lung ultrasound add value to clinical information? So all of you know this. Pneumonia is still a leading cause of death around the world. It still represents a large proportion of the deaths of children under 5. As a general practice in many resource-poor settings, the WHO integrated management of childhood illness is still kind of the main algorithm that is used for the identification of potential. So the WHO integrated management of childhood illness is still kind of the main algorithm that's used for the identification of children that are suspected of having pneumonia and the provision of treatment. The problem with this is that this algorithm still lacks specificity. As a result, I think there could be a lot of false positives, and a lot of kids could be getting antibiotics that shouldn't need to be getting it. So, but what does what do guidelines say about the use of imaging in pneumonia? And I think many of the guidelines are pretty consistent with this, and this is from the American Academy of Pediatrics. It says in the case of children that have uncomplicated suspected community-acquired pneumonia, you really don't need a chest X-ray. You can just get away, or you don't need imaging. You can get away with just kind of a clinical suspicion. But it doesn't. It's not until you actually think about kids who either have an ambiguous case or have children are hypoxemic, where the evidence is that you should be thinking about imaging. And of course, in all inpatients, you should be considering imaging. So as a result, but we have these issues like in many resource-limited settings, X-rays are simply just not available. And could there be another device that could be point of care that we can bring to the patient, or have something that is accessible and also more affordable? So a couple of advantages about a lung ultrasound when compared to X-ray. It's just with the multiple uses of lung ultrasound, especially around obstetrics and around trauma, it's pretty widely available. The ultrasounds have now become small enough that they're like about a laptop sized, and they're portable, they're battery operated. There's no radiation with the use of ultrasound. So at least for kind of just the evaluation of the lungs for pneumonia, you can actually use it multiple times and even over time to see kind of the evolution of pneumonia. It's pretty fast to perform. In our studies, we found that we can actually get the procedure down to less than 10 minutes. And we've also established that it's easy to use and to teach. Kind of our first work on this was to see what other people have done. A lot of the studies that actually the way I became interested in this is actually through my adult critical care practice, because we use ultrasound pretty much for anything. And but then we looked at lung ultrasound as an imaging alternative in both adults and in children. We found that sensitivity and specificity was quite high in kind of both of these cases. And kind of the limitations that we saw was issues of sample size, still heterogeneity in definitions. There was selection bias in how some of the cases were defined. There were variable reference standards. There was lack of blinding. So this led us to think about some potential studies that we can conduct to think about the research. But before that, I wanted to highlight this study, which was recently published in Chest. This is a study by James Sung's group that looked at the feasibility and safety of substituting lung ultrasound for chest radiography in kind of a busy ER in the United States. So here they went ahead and they looked at it was close to 200 kids with suspected pneumonia, and they went ahead and randomized the group to the intervention arm, which is just used a lung ultrasound right away, or just continue with the standard, which is chest X-ray. If there was any clinical uncertainty with the ultrasound, then an X-ray was performed. But the outcomes of the study was to look at the rate of X-ray used, missed cases, subsequent unscheduled healthcare visits, and adverse events. And one of the things that they did find kind of as part of their use is that they were able to reduce X-ray use by 40% in the intervention arm, and actually the reduction got even higher in expert sonographers. And there was no difference between the two arms in cases of missed pneumonia, in adverse events, and in subsequent visits because, let's say, of a missed pneumonia. So again, just showing that this is something that could potentially be a good alternative for chest X-ray use. How about using lung ultrasound in resource-limited settings? Here we had an opportunity to. This was kind of our first entourage of doing a study with lung ultrasound in kind of in a resource-limited setting. We decided to do it in a large referral hospital in Peru. Most of the work that I've had an opportunity to do is being based out of Peru. So here we we approached our colleagues at the Instituto Nacional de Salud de Peru, where we looked at pretty much all the kids that were coming in consecutively into the emergency department, but also extended it to the outpatient clinics and inpatient wards. We did a single visit evaluation. We kind of aimed at children under 5 years of age. We excluded neonates. And we ended up looking at about 832 children with primary respiratory complaints and had a cohort of about 230 healthy controls to be able to compare it against. How am I doing in time? How much time do I have? Still 12 minutes, good. So I'll just go, I'm sorry? 6, 7, 8 minutes. Okay, so I'll have to speed it up a bit. We had kind of a standard approach to kind of defining pneumonia, and also, we were able to do AP X-rays for children with respiratory complaints. So we had X-ray information on all. For lung ultrasound, we did it on all participants. We had general practitioners that was standardized. We had 3 general practitioners that was standardized to a study protocol. And kind of the initial thing was just to do the procedure, not do the interpretation. The interpretation was done later on. Chest radiography was only done in children with respiratory symptoms. We didn't do it on the healthy controls. But kind of at the end of the day, let's see if I have a bit more data here. One of the things that we found is just kind of comparing it, and it's actually kind of similar in range in terms of inter-observer agreement as to what was shown by Nick earlier on in terms of overall, kind of our overall estimates. We seem to have kind of improved when like medium to large consolidations where we got a little bit more of improvement. But when we compared how lung ultrasound performed against chest X-ray, one of the things that we found was similar to other studies, high sensitivity and specificity overall, pretty good area under the curve. And we went ahead and also kind of timed the amount of time it took, because initially we got a little bit of pushback as to, it's going to really be a nuisance in a busy ER. But at the end of the day, it only took about 8 minutes on average in children with pneumonia and about 5 minutes in the control group. The next step is that we had an opportunity to extend our work from Peru to Nepal. And this was, this was funded by NIH. It was a study that were limited to children under 3 years of age. And we wanted to see how adding lung ultrasound to the IMCI, how would it perform? So here as well, in our study in Nepal and Peru, we ended up showing that it took as an average about 6 minutes to perform the lung ultrasound. So it's actually quite quick to be able to perform a lung ultrasound. For this, we actually had an opportunity to look at kind of the separations of kind of the IMCI criteria, thinking about children who met criteria for WHO pneumonia, and children who had respiratory symptoms but didn't meet the criteria for either tachypnea, didn't have some of the danger signs. One of the things that we actually found is that these are groups of children that actually had respiratory symptoms. What you would expect is like in the group with WHO pneumonia, we were only able to find maybe 1 out of 5 that had a consolidation that was suggestive of pneumonia. Very similar to what's actually seen in X-ray studies. But what's surprising to us too is that even in the arm that had respiratory symptoms that didn't meet the criteria, we still saw about 1 in 5 consolidations. In using our data from the Peru study in the group of 800 children that had respiratory symptoms, about a quarter of them had a confirmed pneumonia by X-ray. So we wanted to we built these kind of 3 additive scenarios under which we saw what would happen if we looked at reported symptoms and clinical signs only, addition of lung auscultation and pulse oximetry, and addition of lung ultrasound findings. So here in this study, we found that, just when it came down to respiratory symptoms, respiratory rate, and danger signs, the most salient sign was actually chest indrawing that had a significant odds ratio. But the area under the curve was about 0.6. When we went ahead and added findings on auscultation, we found that having crackles, of course, or wheezes increased the chances of having a pneumonia, but didn't really increase the area under the curve It increased it a little bit, and it was significant compared to just having symptoms and signs alone. We also then looked at oxygen saturation. Oxygen saturation add any information once kind of beyond what we saw in B or A. For our particular scenario, we didn't see that having oxygen saturation added any information, but it is very possible that because we were already working in a ED where kids were actually coming, they were quite sick, and we knew that they had a suspected pneumonia, that having the additional information of oxygen saturation wasn't adding much more than either auscultation or respiratory symptoms. But when we looked at lung ultrasound, we saw that if you had a consolidation or interstitial abnormalities, they were both predictive of having kind of an X-ray confirmed pneumonia, and it increased the area under the curve to about 0.85. So obviously adding a good amount of value. The last thing I would just want to mention is work that we're doing concurrently with Eric McCollum and with Abdullah Baki from Hopkins. This are kind of the T fields in Sylhet. So it's actually good. You have an opportunity to visit at some point. It's quite pretty. But we're doing this. We had an opportunity to join both Eric and Abdullah in this study. It's actually funded by the Gates Foundation. It's to join a pneumococcal conjugate vaccine surveillance study and be able to include ultrasound into the surveillance activities. Here we focus a good amount on what's kind of the best method to teach ultrasound. We had an opportunity to expand on our teaching program that we had worked in Peru, and worked on teaching 18 Bangladeshi physicians and getting to at least over 80% agreement in them. Then the other thing is that we've actually just finished the study over kind of this 2.5-year period of data collection. We have close to about 9,000 lung ultrasounds performed, and about 27% of them had positive findings. And there's a wealth of information here. We have information on chest X-ray as well, and we'll be able to, we're kind of in the midst of analyzing these data. I think that's all I'll mention right now. So kind of in conclusion, we believe that lung ultrasound is a promising tool for the diagnosis of pediatric pneumonia, especially in resource-limited settings where X-rays may not be available. Has high sensitivity and specificity when compared to just a clinical diagnosis. It can actually be performed quickly without major disruptions to workflow. It's actually in our Peru study, once we ended the study, the Instituto Nacional de Salud de Peru was kind of upset with us because it was like, he said, we had you as a resource. You were just doing ultrasounds for us, and we're already using this as part of we're already thinking about using it as part of our intervention. So why do you take away your physician who was doing it? There was high agreement among practitioners. It's actually pretty well tolerated by children as well. And the other thing that's portable, and I think the added win is that it has no radiation. So thank you.
Thank you very much, Will.
Yes.
We're ready to take questions from any audience members that may have questions to any of our speakers. Do we have in the back?
Thank you. I just wanted to ask you, what's your experience to using ultrasound to diagnose tuberculosis?
I'm sorry, can you repeat that one more time?
Your experience using ultrasound to diagnose tuberculosis.
Actually, the person
In children, of course.
So the person that could potentially answer that, I think, Mirko, have you been working with Bob on tuberculosis and lung ultrasound? Can you tell us a little bit about what you've done? I haven't had experience. I haven't focused on tuberculosis, but Mirko is the one who's been working on that, so he can tell you a little bit about it. I'm sorry to put you in the spot, so now you need to give all your results.
Yeah, no, just something brief. Regarding ultrasound, we have been following Will's studies, trying to use the evidence that he has shown and trying to figure out if the reading of ultrasound can be simplified by automatizing it with some mathematical algorithm to interpret images. The preliminary results are very promising, The problems are that ultrasound equipments are not all of them able to share the data in real time so that we can have the analysis just in real time. There is a couple of companies that are doing so, but unfortunately the quality is not that good as the larger equipments. But as we have been talking with Will before, it is just an issue of waiting for the industry to build different equipments with these capacities to have us analyze the data in real time.
Yeah. Well, thank you. So yeah, so Bob Gilman's group is the one that's been thinking about ultrasound and tuberculosis. And it's not something I've done, but you have to make sure. I think the advantages and disadvantages of ultrasound. So one of the disadvantages is that you need to have disease that gets to the pleura, because if there's no fluid that gets to the pleura, then there's no conduction. So that's, you got like a pneumonia that's early on, it's very central, then you'll miss it. And TB, I imagine when it's severe enough, it's all over the place, and then you can see stuff. But if it's kind of remains central and you have kind of a nice little cavitation, you may not be able to see it if there's no contiguity with the pleura.
Any other questions for any of the other speakers? As well as could also be another question for Will. Andrew, do you have a question that you were going to ask earlier?
Thanks. It was to Nick Boyd, just in terms of the probe. I was just wondering about using between patients and ease of cleaning it from an infection control standpoint.
Yeah, it's a very good point. And we were asked that earlier today. So it's a reusable piece of medical equipment that we recommend being cleaned in between each patient, like so many bits of kit that's out there. It's only going on a child's finger or foot, and we recommend cleaning the foot before it's put on. I think it's very difficult to know the cross-infection risk between patients. All I can say is that it's routine practice in many high-resource countries to be using bits of medical equipment between patients. Certainly in operating theatres in the UK, we use reusable pulse oximetry probes for every patient, blood pressure cuffs, various bits of kit in between patients, and it's just contacting the skin, but we do recommend cleaning it, and it's easy to clean.
And you clean it with alcohol?
Yes.
And it's durable? But
it is, yeah, exactly, yeah. So it's been designed so that so that it will withstand alcohol wipes and soap and water, just warm soap and water, absolutely.
Maybe time for one more question.
Thanks. This is just a question for Will. Thanks for your talk. I just wondered if there was any work that you've done on severity scoring using ultrasound and the overlap, as you mentioned, with pleural disease and pleural effusions, empyema, that sort of thing.
Not yet, but I think with our large database from the Bangladesh study, I think that's going to be an opportunity to look at many of those questions, including severity. But thank you.
Okay, so I think maybe we'll wrap up the session. Thank you for coming. Please keep child pneumonia high on your agenda moving forward. And tomorrow I just did want to mention that there'll be a child health section for the union. So for those of you who are interested in child health in the context of even TB and beyond, please attend. It'll be held at 7:30 a.m. and where specifically, Andrew? Or I guess it's in your booklet, but tomorrow 7:30 a.m. Please come. Thank you for attending today, and have a good rest of the meeting.